Welcome to this video lecture on the physiology and management of fetal hypoxia. In this video, I will be providing an overview on the physiological changes of fetal hypoxia during labor. I will be describing the features of each type of hypoxia, then discussing the management options for the different types. At the beginning, I would like to highlight the difference between hypoxemia and hypoxia. Hypoxemia describes an abnormally low concentration of oxygen within the fetal blood. This is inevitable. This will occur every time the fetal cord gets compressed or if the uterine contraction lasts beyond the capacity of the placenta reserve. While hypoxia is the presence of abnormally low oxygen concentration within the fetal tissues. This can be generalized, as in involving the entire fetal body, or more commonly localized, involving certain areas of the fetal body to divert oxygenated blood to other more important regions, a process which we call redistribution. As I just said, hypoxemia is inevitable during labor, and it generally has minimal, if any, effect on the fetus. However, it is important to note the response of the baby to hypoxemia, as this will help reassure us that the fetus is happily coping with the process of labor and would allow us to titrate the management of labor to a level which the specific baby that we are monitoring can safely cope with. It is the signs of development of hypoxia that we are more concerned about, and being even more specific, we are most concerned about signs of hypoxia of the fetal central organs, namely the brain and the heart. We tend to describe hypoxia in four scenarios: acute, subacute, gradually evolving, and chronic hypoxia. And we will be discussing each type or scenario in turn. As it is the most dramatic, let us start by discussing acute hypoxia. Acute hypoxia presents on the CTG trace by a prolonged deceleration. By definition, this is a deceleration that lasts for over 3 minutes. This becomes more significant if it lasts for over 5 minutes. Causes of acute hypoxia include placental abruption, cord prolapse, uterine rupture, prolonged uterine contraction, hypotension, and prolonged cord compression. The common theme between all these causes is that there is almost complete interruption of the fetal oxygen supply, hence widespread hypoxemia leading to rapidly developing generalized fetal hypoxia. Basically, the entire body of the fetus is going into anaerobic metabolism, which is why the fetal pH drops rapidly at a rate of 0.01 per minute as the carbon dioxide produced by the fetal body is accumulating in addition to the lactic acid being produced from the anaerobic metabolism. You might have noticed that I divided the causes into two groups. The first group are irreversible causes, so fetal oxygen supply has been interrupted and there is no way I can restore this. Hence, I need to deliver this fetus. While the other group are reversible causes. Oxygen supply has been interrupted, but I can restore it by removing the offending cause. Luckily, irreversible causes tend to be uncommon, and hence, most of the time, there is something that we can do to reverse the process of acute hypoxia. How do we manage acute hypoxia? When I talk about management, I will be discussing both diagnosis of the presence of acute hypoxia and then how to treat it. With acute hypoxia, the diagnosis is probably the easiest. You can see a deceleration that is lasting for over 3 or 5 minutes, hence the diagnosis already being made. The real problem is, when do you actually make the call? We just said that acute hypoxia involves widespread hypoxemia and anaerobic metabolism. This can be significantly damaging if left untreated, so we need to make the call pretty early in the process to ensure that the baby is delivered unharmed. The balance is, though, that you do not want to be pulling the emergency alarm too frequently with every deceleration you see. There is a well-known management rule for acute hypoxia, the 3, 6, 9, 12, 15 minute rule. We will adhere to this for the management of acute hypoxia with some minor changes. If the deceleration has exceeded 2 minutes, With no evidence of recovery, you need to start your conservative measures, turning her onto her side, stopping the syntocinon infusion. If you are reaching the 3rd minute, you need to pull the emergency alarm. You are aiming for your team to be in the room by the end of the 3rd minute. This obviously applies to the fetus that has previously shown normal variability and cycling. If there are obvious signs of an irreversible cause, for example, you can see evidence of an abruption, or you can see the cord prolapsing through the vagina, or if you are aware that this fetus already had reduced variability and cycling before the deceleration started, I would not suggest that you wait for the 3 minutes before you pull the emergency alarm. Once the team is in the room, we now need to make the diagnosis. Not of acute hypoxia, as that is pretty obvious from the prolonged deceleration, but initially of the cause of why the hypoxia is happening. You are trying to figure out whether this is a reversible cause or an irreversible cause. The second part of the diagnosis is figuring out how much does this fetus have to fight off the acute hypoxia. Look at the baseline and variability before the hypoxia started. This tells you whether the baby was already hypoxic before the deceleration. Then look at the variability during the first 3 minutes of the deceleration. This tells you whether the baby's brain has become ischemic just as the deceleration started. Finally, you need to look at how the baby is coping at this point in time, whether variability and hence fetal brain oxygenation is still maintained, and whether there are any signs of recovery. The process of making the diagnosis should not take more than 3 minutes, hence by now you are at 6 minutes from the beginning of the deceleration. At the end of those 6 minutes, you need to make a decision. Either you have an irreversible cause for this acute hypoxia, in which case you need to deliver this baby with the fastest, safest route possible. Or you have a reversible cause, but you can see evidence of poor reserve, in which case the baby still needs urgent delivery, as the hypoxia would be too damaging to await treatment. Finally, and more commonly, you have a reversible cause and a baby that had a good reserve before the deceleration, in which case you need to treat the cause immediately. We are now assuming that the babies that needed delivery are on their way to be delivered. Hence, we will be praying for a safe delivery for mom and baby and will not be discussing them any further. We will continue, however, with the other group which we decided to treat. Now, the midwife in the room was very smart. When she noticed the prolonged deceleration developing, she asked the lady to turn onto her side and pull the emergency buzzer. The first thing I did when I came into the room, however, was to ask her to turn onto her back for me to examine her. Please do not forget to ask the lady once again to move off her back. If this lady was on Synto, I would assume that the midwife has already by now stopped the Synto infusion. If not, please stop it. If it had already been stopped, or she was never on Synto to start with, and you still have an ongoing uterine contraction, you need to administer a tocolytic immediately. In our unit, we use subcutaneous terbutaline. If the hypoxia is caused by hypotension, starting rapid IV fluids, if clinically safe, may help improve the perfusion of the uterus and hence the placenta. If the anesthetist is around, administration of ephedrine may also be quite helpful. Administering the treatment should not take more than 3 minutes. This now takes you to 9 minutes from the start of the deceleration. Now that you have administered the treatment, you need to observe for signs of improvement over the next 3 minutes. The variability that may have been previously lost or exaggerated should be returning to normal, and the fetal heart rate may be starting to return to the baseline. If the fetal reserve was good before the deceleration and the variability was maintained in the first 3 minutes, 90% of babies would recover by 6 minutes and 95% would recover by the end of 9 minutes, obviously considering that we had a reversible cause. If there are no signs of improvement, you most likely missed one of the irreversible causes, and by now you are 6 minutes late and you need to deliver this baby as soon as possible. If the baby has started to improve, you need to observe the baby for further improvement and try to figure out what caused the incident of hypoxia to start with, and hence be more cautious as you proceed with your management. As a recap, The management of acute hypoxia starts by making the call, i.e. pulling the emergency buzzer if you can see a deceleration that is lasting for 3 minutes with no signs of recovery. You are aiming for the team to be within the room by the 3rd minute. The next 3 minutes is spent making the diagnosis, as in the cause of hypoxia, the fetal reserve, and the current fetal status. And at the end of those 3 minutes, you need to make the decision. You're either delivering as soon as possible or you're treating as soon as possible. Treatment should not take more than 3 minutes, and then you reassess over the final 3 minutes. This is a simplified flowchart describing the management of acute hypoxia. SubAcute Hypoxia. SubAcute hypoxia presents with the fetus spending more time responding to hypoxia than at the baseline. This is frequently associated with episodes of exaggerated variability or panic response. In subacute hypoxia, the drop in tissue oxygenation is still fast, even though it is less dramatic than in acute hypoxia. Hence, the pH drops at a rate of 0.01 every 2 to 3 minutes rather than every minute. The cause of subacute hypoxia is either an increase in uterine activity, be it spontaneous or due to uterotonics, or due to maternal effort in the 2nd stage. The general theme of subacute hypoxia is that the placenta and fetus are not getting enough time to refresh their oxygen stores. How do we manage subacute hypoxia? Once again, management means diagnosis and treatment. In this case, the diagnosis is pretty straightforward. You see a baby that is spending more time in decelerations with episodes of increased exaggerated variability, and you can see that the mother is contracting quite frequently or that she is starting to push. In subacute hypoxia, however, you can preempt the diagnosis and titrate intrapartum care to prevent subacute hypoxia from happening in the first instance. If you notice that the contractions are becoming less than 90 seconds apart, or the contractions are lasting for over 90 seconds, or that the uterus is not relaxing properly in between contractions, this baby is heading towards subacute hypoxia, even if it appears to be coping well at the moment. If this is secondary to uterotonics, it is advised to reduce the oxytocin infusion rate to ensure the safety of the fetus. If the contractions are spontaneous, it is important to observe the fetus very closely for any signs of progressing hypoxia. If you can see signs of subacute hypoxia, you need to treat it by treating the cause. You try to give the baby and placenta more time in between contractions to restore their oxygen stores, in addition to making this time count for more by improving the uterine and placental perfusion. We reduce the uterine activity by stopping or reducing the uterotonics and improving the perfusion by avoiding supine position, or positions which cause prolonged cord compression. If we are not improving, we relax the uterus even further by administering tocolytics, and we can give rapid intravenous fluids to transiently improve uterine perfusion. If subacute hypoxia is occurring in the 2nd stage and is secondary to maternal effort, you will advise the mother to stop pushing until the fetus has returned to a stable status. Once the fetus is better, we can resume pushing, observing the fetal response. Sometimes it helps to push with every other contraction to increase the resting time for the fetus. If we cannot improve the fetal status by any of the previous measures, which is quite uncommon, then we need to expedite delivery with the fastest, safest route possible. Gradually evolving hypoxia. Gradually evolving hypoxia is the most common type of hypoxia seen in labor. It is the most dangerous, as it is the most frequently missed. The hypoxia develops gradually over time, giving the fetus time to adapt to the hypoxic environment and employ its protective mechanisms. Let us consider the scenario by which gradually evolving hypoxia presents. We are going to demonstrate this on a normally well-grown fetus at term. If you perform a CTG for this baby, you will notice a baseline which is appropriate for its gestational age, and more importantly, is in keeping with the heart rate which had been observed during the antenatal period. You can see this by reviewing any previous antenatal CTGs or by reviewing the documentation of fetal heart rate at the antenatal clinic reviews. You will notice that the fetus has normal variability and is demonstrating normal transitions between the different behavioral states, which we call cycling. The baby would demonstrate accelerations on the trace, and if the mother is not in labor, would not show any decelerations. Once the mother goes into labor, the uterine contractions may occasionally cause cord compressions, and this presents on the CTG by the appearance of decelerations. Cord compressions can become more frequent once membranes have ruptured and the amniotic fluid has drained, and hence decelerations may become more frequent. As we mentioned earlier though, cord compressions are associated with transient hypoxemia and not hypoxia, and this would have minimal if any effect on the fetus. The fetus will still have a normal baseline heart rate, normal variability and cycling, and normal fetal activity. Imagine yourself wearing a scuba gear in the bottom of the ocean. You are happily swimming around, enjoying the view, and suddenly you notice that the oxygen flow from the tank is being recurrently temporarily interrupted. My first response in this situation would be to pay attention to what is going on. I would not be performing any unnecessary movements and definitely would not safely fall asleep. Similarly, if the contractions get even stronger and the cord compressions become more intense or are lasting for longer episodes, the baby will become more aware of them and would reduce any unnecessary activity and would not be falling asleep. Hence, you would notice that although the trace has a maintained baseline rate and variability, accelerations would be infrequent or absent, and there will be no evidence of cycling. Obviously, the decelerations would continue as a response to the cord compressions. As the contractions become more intense and the episodes of hypoxemia more pronounced, the decelerations will become wider and deeper, but once again, the fetus will still have a normal baseline and maintain variability. This tells us that although the fetus is facing a recurring hypoxic stress, it is perfectly capable of coping with that stress and has not needed to use any extra resources to cope with that stress. But if the hypoxic stress becomes even stronger and more intense, the fetus will need to start employing compensatory mechanisms to cope with this ongoing stress. The fetus starts redistributing its oxygen supply from peripheral, non-essential organs to more central, more essential organs. The mechanism by which this distribution is brought about is by the release of catecholamines from the adrenal gland. And the first response the fetus would have to the release adrenaline is an increase in heart rate. Redistribution is not an all or none process. It is a gradual process that occurs over time. The fetus will sacrifice its peripheral tissue by order of least to more important organs. So starting from vasoconstriction affecting the skin, followed by muscles and bones, followed by bowel, kidneys, liver. Notice that during this process of redistribution, we started off by seeing a rise in baseline with the release of adrenaline. Apart from the decelerations becoming deeper and wider with further increasing intensity of the contractions, there are no further signs on the trace during the process of redistribution that we would or could have noticed so far. As the hypoxia progresses, however, the next organ to go into vasoconstriction would be the fetal brain. And this would present on the trace by a reduction in variability, initially during the decelerations and later at the baseline even between contractions. With the progress of brain ischemia, the protective mechanisms that the fetus was employing during the episodes of hypoxia would cease to function, as they obviously require fetal brain function. Basically, the hypoxia is reaching a stage when the fetus can no longer compensate for the recurring hypoxic stress. We call evidence of brain ischemia signs of decompensation. To describe the CTG, the baseline heart rate would be raised from the circulating adrenaline hormone, the variability would be reduced due to brain ischemia, accelerations would be absent, and decelerations would gradually become shallower as the brain can no longer respond to the hypoxia. If the hypoxia progresses even further, the baby's heart will become ischemic and would enter a process of terminal heart failure, with a step-ladder pattern drop of the fetal heart rate. This pattern is frequently described as the step-ladder pattern to death. And this will finally end in a stillbirth. As a recap, gradually evolving hypoxia starts with showing evidence of hypoxic stress, basically decelerations on the trace. As it gets worse, the baby loses cycling and reduces its activity. The decelerations start becoming deeper and wider with further progress, and then the baby starts compensating by releasing adrenaline, and the baseline goes up. Up until the release of adrenaline, this process is of worsening hypoxemia, which we said has minimal if any effect on the fetus. Once adrenaline is being released, however, the baby is starting to redeploy resources to cope, which is causing peripheral hypoxia. Once this hypoxia reaches the brain, the baby starts entering the stages of decompensation and brain damage. You may have noticed that the arrows between the different stages are going in both directions. As you can reverse this and improve fetal status at any stage. Even short episodes of brain ischemia can be reversed with minimal effect on the fetus. However, we must remember that even though fetal tissues are quite resilient, prolonged ischemia can cause fetal tissue damage and does increase the fetal acidemia due to anaerobic metabolism in the tissues. Acid in turn is damaging to tissues and reduces the oxygen carrying capacity of hemoglobin. Once you have reached heart ischemia, the damage is irreversible, in addition to the fetus not being able to employ any compensatory mechanisms anymore. So we diagnose gradually evolving hypoxia by being vigilant in monitoring the fetus during labor. As we repeatedly said, hypoxemia is not significant during labor. However, if I notice that the fetal cold compression appears to be more exaggerated while the mother is in a certain position, I would recommend avoiding that position. If I can see that recovery from contractions is taking longer while she's on her back, I would recommend changing the position to be in the position which the baby suffers least. If I'm noticing that the hypoxia is becoming worse, I would reduce the Synto rate if on Synto. Advise her to drink a bit more if she appears dehydrated. Basically, I am trying to improve the fetal status at any stage. If I can see that we have entered the stages of compensation, I would be more vigilant in improving the fetal condition. And obviously, this becomes more urgent if we are facing decompensation. If signs of decompensation cannot be reversed, urgent delivery is required. Chronic hypoxia. Chronic hypoxia is actually a hypoxia that develops during the antenatal period. This reduces the fetal reserve and makes the baby more susceptible to injury due to intrapartum hypoxia. There are three cardinal signs of chronic hypoxia: a high baseline rate, reduced variability, usually associated with absence of cycling, and shallow decelerations, usually associated with absence of accelerations. When assessing the baseline heart rate, it is important to always go back to the antenatal fetal assessments for the appropriate rate expected for this specific fetus. This image is of a baby that was diagnosed with chronic hypoxia. You would see that the baseline rate on this trace is 140 beats per minute, which is appropriate for gestational age. This baby, however, always had a heart rate of around 110 to 120 during the antenatal period. Hence, this heart rate was persistently raised for this baby. The cause of chronic hypoxia is reduced placental supply of oxygen and nutrition during the antenatal period. This can be due to many causes, but regardless of the cause, the end result is a reduced fetal oxygen supply. Now let us discuss the progress of chronic hypoxia during the antenatal period. We have agreed that we have an element of placental insufficiency, and this has led to reduced oxygen supply to the fetus. Once again, this is not an all or none phenomenon. There is a wide clinical picture depending upon the degree of reduction of supply. In its mildest form, although the oxygen supply is reduced, the supply is enough for daily activities, movements, and growth. It is not enough, however, for the fetus to save this for future use, hence fetal reserves are reduced. If hypoxia is worse and supplies are further reduced or compromised, this affects fetal growth, even though daily activities and movements are still maintained. So far, these babies have been completely asymptomatic and may only be picked up on an incidental ultrasound scan. If supplies become even shorter, similar to gradually evolving hypoxia, the fetus will start to redistribute its resources to maintain important organs and functions. And once again, this process of redistribution is facilitated by means of a higher base level of adrenaline release from the adrenal gland. Hence, the first sign to be noted is a relative tachycardia or increase in heart rate from the measurements previously noted. Then the fetus will once again start sacrificing less important organs. Notice that this time, as this is occurring over the span of months, it is not about complete vasoconstriction, but about less blood supply, hence less development. The order of sacrifice follows a similar pattern to that of gradually evolving hypoxia. Now, we did not mention the fetal lungs when we discussed gradually evolving hypoxia. We frequently say or hear that fetal lungs are not as important during intrauterine life, as they have no role in providing oxygen to the fetus. Interestingly, the lung receives 8 to 9% of the combined cardiac output during intrauterine life, which is almost half of the blood which the entire body gets if we exclude the heart and brain. This is because although the lungs have no role for oxygenation during intrauterine life, they undergo a large amount of growth and development. Hence, when we consider that the fetus has reached the point of having to sacrifice the lungs for heart and brain supply, this will not only have a significant impact on reserves during labor, but also on the capacity to transit from intrauterine to extrauterine life after birth. As hypoxia progresses, this would affect intrauterine brain perfusion and can finally end with intrauterine fetal death. In short, babies suffering from chronic hypoxia start labor with a reduced reserve and already compensated for hypoxia, with a high baseline, reduced variability, and blunted responses. This means that they lack the capacity to cope with further stress, and hence they increase susceptibility to injury from further hypoxia. How do we manage chronic hypoxia? Starting once again with the diagnosis, we start by risk assessing the mother for risk of development of chronic hypoxia by exploring any prenatal risk factors. We then proceed to explore the antenatal history for signs or symptoms suggestive of chronic hypoxia, paying special attention to fetal movements during the time leading up to labor. When presenting in labor, we look for the cardinal signs of chronic hypoxia. We basically ask or assess whether the fetal heart rate is appropriate for this baby and gestational age, whether this baby has normal variability in cycling, the presence or absence of accelerations, shallow or late decelerations, and we consider the wider clinical picture for this baby. And finally, once we have made the diagnosis, it is crucial to be extremely cautious if you are planning any intervention that may increase the risk of hypoxia, with a low threshold for surgical interventions. Thank you very much for your attention. I hope you have enjoyed this video.